Welcome to my another episode. This is secondary amenorrhea, absence of 3 consecutive menstrual cycle in a row in a woman who has first menstrual period. The common cause for secondary amenorrhea is pregnancy, but there are other causes in the hypothalamus, pituitary causes, ovarian causes, or in the uterus, because this is the hypothalamic pituitary axis and an intact uterine genital tract. There are other causes and physiological causes. So we will go in detail one by one. The commonest causes, that is pregnancy, as I told you. Now we will start with the causes. Causes of secondary amenorrhea, excluding pregnancy. The commonest cause is hypothalamic dysfunction, polycystic ovarian syndrome in pituitary diseases, ovarian non-polycystic ovarian disease, uterine disease, and others. The commonest is polycystic ovarian disease. Secondary amenorrhea. If we take the hypothalamic cause, there are mainly psychological disorder that counts for 1/3 of the hypothalamic causes, mainly related to the weight and exercise. Excessive weight loss lead to hypothalamic cause of amenorrhea, or exercise that will lead to amenorrhea. Another cause of secondary amenorrhea is, as we talked, hypothalamic causes and pituitary causes. Hyperprolactinemia is one of the cause for secondary amenorrhea. Prolactin is secreted by the anterior pituitary, which is regulated by inhibition of the hypothalamus by dopamine. Hyperprolactinemia is defined as fasting level more than 25 nanogram per ml in a woman at least 2 hours after waking up. There are causes, either they are physiological causes, pathological causes, or due to use of some medication. Physiological causes are pregnancy, lactation, exercise, or stress. Pathological causes are pituitary tumor, PCOS, hypothyroidism. If you use some medication, due to that there is hyperprolactinemia. High dose of estrogen, antipsychotic medication, antiemetics, proton pump inhibitor, or methyl dopa. 1 to 2% is by drug that inhibit the serum dopamine concentration. 50% of the patient with hyperprolactinemia have galacturia. Pregnancy due to hyperstimulation of peripheral estrogen derived from the placenta. Level of prolactin are 4 to 20% higher than the non-pregnant woman. After delivery, in non-lactating women, it will take 15 to 20 days to reach to normal level. In lactating women, circulating level maintained by sucking, and that lasts for 2 years. Pathological hyperprolactinemia may be induced by drugs that inhibit dopamine action or production. Medicines mainly are chlorpromazine, prochlorperazine, and haloperidol, metoclopramide, cimetidine, methyl dopa, and many others. There is the level of prolactin, and these prolactin levels will be, as you saw, from the hypothalamus there is stimulation, and dopamine is the inhibitory factor. If dopamine will release, it will decrease the prolactin level. In milk secretion, anovulation, and other reasons are FSH is low, LH is low. These are all leads to hyperprolactinemia. These are the pituitary causes. In 20 nanogram, 100 nanogram, and 250, it will give us mild, normal, moderate, and severe. Idiopathic causes are there, drugs as I told you, prolactinemia, macroprolactinemia. If there is any interruption in the pituitary stalk, it can lead to hyperprolactinemia. If there is hypothyroidism, chronic renal failure, there is a chest injury, hepatic failure, polycystic ovarian disease. These are the things can lead to hyperprolactinemia. How to do the workup for hyperprolactinemia? We have to take the detailed history. Is the patient is taking any medication or is it idiopathic? If there is persistent hyperprolactinemia, we have to assist for macroprolactinemia. We have to ask for beta-HCG, thyroid function test, creatinine and AST. This is all depend upon the assay of prolactin. Then if it is still high, then you will go for pituitary MRI. It can give you prolactinoma or idiopathic hyperprolactinemia, or there is any cellular masses of pathology. How to manage the hyperprolactinemia? We should know the definition of macroadenoma. It is less than 1 centimeter, micro is less than 1 centimeter, and macro is more than 1 centimeter. Now, how to manage hyperprolactinemia? As I told, a detailed history, drug history, any physiological, you have to exclude the pregnancy. Whenever it is high, always repeat the prolactin level. If it is normal, then you are leaving it, look for other causes. If it is elevated, you ask for thyroid stimulating hormone level. Either it is normal or elevated. If it is normal but prolactin is high, you have to ask for MRI or CT scan. If CT scan is done, either it is normal or there is hyperplasia, there is macroadenoma or microadenoma. If it is normal, you have to repeat the MRI after 6 to 12 months. Macroadenoma, you can treat the patient by medical. But if it is macroadenoma, it needs medical management. It will not regress, then it will go for surgical treatment. Medical treatment is by dopamine agonist, bromocriptine or carbogoline. If it is hypothyroidism, we have to treat the hypothyroidism. Repeat prolactin and TSH after 6 to 12 weeks. If it resolves, then continue the medication. If it is high, then repeat the investigation and proceed as per protocol. Now, we have finished our hypothalamus causes, pituitary causes. Now we comes to the ovarian causes. Ovarian causes are either it is due to aging or polycystic ovarian syndrome, Turner syndrome, premature ovarian insufficiency, autoimmune disorders. Either the ovaries are removed due to certain cause surgically or post-cancer treatment by radiotherapy or chemotherapy. Number of follicles in human ovaries decline steadily from midlife onward, and this process is irreversible as organal stem cells disappeared after birth. The loss of follicle is age dependent and the rate of disappearance increases with age. As you are growing, the number of eggs will be reducing. Premature ovarian failure. What is premature ovarian failure? It is a triad of amenorrhea, estrogen deficiency, elevated concentration of FSH/LH, and the patient age is less than 40. Then we consider is premature ovarian failure. Now, the commonest is the PCOS. The exact cause of PCOS is unknown. It is an insulin resistant. There is increased male hormone, that is androgen, low grade inflammatory and hereditary component play a role. But exactly the role of which factor is more influence is unknown. The prevalence of PCOS is 15 to 20%. So we have to check what is the way we can diagnose. Either it is diagnosed by National Health Institute in this clinical and biochemical hyperandrogenism, oligo and amenorrhea or anovulation. If we use Rotterdam, this criteria, there are 2 out of 3 are required, like clinical or biochemical hyperandrogenism, oligo or amenorrhea or anovulation, polycystic ovaries on ultrasound. Detailed management we will discuss later on. Now comes to the Turner syndrome. One of the sex chromosome is missing or partially missing. In this chromosomal defect, 2/3 has one chromosome and the rest has structural abnormality of one chromosome, or they display as mosaicism. 25% of normal chromosome pure gonadal dysgenesis, they have streak ovary. 50% of the Turner have ovarian dysgenesis. If you see this photo, the woman or a girl is short stature, web neck, low hairline, they have cardiac abnormalities, their nipple are widely spaced and their cubitus valgus, they have streak ovaries, infertility, and they have peripheral edema at birth. So this is one of the chromosomal abnormality. As we talked about the premature ovarian failure, it happened before the age of 40. In this, there are different causes that lead to premature ovarian insufficiency, fragile X syndrome. In this, there is inherited form of mentally retardation. Autoimmune diseases are mainly 10 to 20%, Addisonian disease, hypothyroidism, pernicious anemia, Hashimoto's disease, idiopathic thrombocytopenia, rheumatoid arthritis with vitiligo, alopecia areata, Cushing disease, autoimmune hemolytic anemia, myasthenia gravis, or mumps or tuberculosis. In hyperthyroidism, level of sex hormone binding globulin increases, hence the increased circulating concentration of estrogen and testosterone. In hypothyroidism associated with increased level of prolactin due to stimulation of thyrotropic releasing hormone. When the cause is adrenal, in adrenal diseases, excessive secretion of steroid lead to amenorrhea and there is suppression of gonadotrophin secretion suppressed. Now, the other cause is uterus. We already discussed hypothalamus, pituitary. Now comes the third cause, that is the uterus. Uterine cause is when there is damage to the endometrium as a result of intrauterine adhesions, Asherman syndrome, or due to some reason there is excessive cervical stenosis. This will lead to amenorrhea. Physiological causes, as we told you, pregnancy, lactation, and after menopause, definitely there will be no periods. Now we discuss all the causes of secondary amenorrhea. Now we will do the investigation to reach a diagnosis. We took the history. Now we will do the investigation to reach to a diagnosis, and we will treat the patient. Investigation of secondary amenorrhea is, in all cases, first test to be done is the pregnancy test. If pregnancy test is positive, no more investigation. If it is negative, then we have to ask for thyroid stimulating hormone and prolactin level. If this is normal, then we have to go for progesterone challenge test. In progesterone challenge test, either there is a withdrawal bleeding or there is no withdrawal bleeding. If there is withdrawal bleeding, the cause is normogonadotrophic normogonadism. But if there, after giving a progesterone challenge test, there is no bleed, then we have to do the priming by estradiol followed by progestin challenge test. In this also, either there is bleed or no bleed. If there is no bleed, it means it is Asherman syndrome. There is the lining of the uterus is damaged. But if there is withdrawal bleed, then we will ask for FSH and LH. If it is between 20 to 40, it is hypergonadotrophic hypogonadism. That means it is ovarian insufficiency. If it is less than 5, it is hypogonadotrophic hypogonadism. You go for MRI. When the FSH-LH ratio are abnormal, testosterone and diaz are moderately high, think about polycystic ovarian syndrome. If 17-hydroxyprogesterone is high adult level, then the cause may be adrenal hyperplasia. If it is 2 times higher than the polycystic ovarian syndrome, then think of androgen secreting tumor. Either it is from ovary or gland or hypertrichosis. Now, if there is high TSH, it means hypothyroidism. Prolactin is normal. If TSH is normal but prolactin is high, you have to know the level. What is the level? Is it more than 100 or less than 100? If it is less than 100, then you have to exclude the causes for high prolactin. If it is more than 100, go for MRI and find out is there is any prolactinemia, NOMA or not. If MRI is normal, then look for the reason of high prolactin. Look in the history. The treatment. Treatment is treat the cause. If pregnancy test is pregnant, patient will be treated as a pregnant. If she is breastfeeding, then look, you can continue the breastfeeding. If she has irregularity, you can use the pills. If there is excessive weight loss, advise her for proper exercise, proper eating, and not to eat too much to become too obese. They can go for professional advice and management. If they are too stressed, they should go for psychological treatment, and tender loving care is very, very important. So treatment of secondary amenorrhea is according to the cause. I hope you like my videos and it will help you in education and preparation of your exam. Feel free to subscribe my channel, and if you want any comments or any question, below down is the comment box. I will answer you and I will prepare the video in future for you.